we continue to do things even though we know it's not good for us. So it's kind of like a weird thing. Like, why do we do that? Why do humans continue doing things that are bad for them? We do this in many ways, not just with food, but it's interesting. So what GLP-1s do, it's almost as like a pause factor. It like causes us like pause, like this delayed, I like to call it a delayed instant gratification. It's called the pause factor. And we teach patients, like, try to notice how this is happening in your brain, where you see something, you want something, and your old self would go for it and take it. But your new self on a GLP-1, you all of a sudden like, I'm going to pause. And it's not really like humans to pause. We like to react really quickly.
For sure.
So I kind of think if we continue like channeling these parts of the drugs, maybe even making it better, like if we were on these medications, would we all of a sudden become less reactive to multiple things in our life? And that's kind of cool. Like if we could all take a drug to be less reactive, less impulsive. I mean, I look at that as like a good thing.
Hello and welcome back to another episode of the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher, and it's a pleasure to be back with all of you. Today's podcast was very cool. We dove deep into GLP-1s. Hot topic, everybody. Everybody's taking them. Everybody wants to take them. Everybody hates them. All these kinds of things. And I got into it with somebody who knows more about this topic than many because she's using them personally and also professionally for many, many years. I'm talking about my guest today, Bracha Banayan. So Bracha is in New York City. She's a family nurse practitioner. She's the CEO and founder of IV Drips and Hasty Meds. Her mission is making healthcare seamless, providing true connection and empowering patients through education via IV home services, on-demand prescriptions, and weight loss with GLP-1s. And I wanted Bracha on because she's a wealth of information and clinical applications of GLP-1s. We discussed how she uses them in clinical practices, and we talked about various aspects of them, the types of GLP-1s, how they're working in the body, not only in the GI system, but also in the brain, how she's using them for obesity, for alcoholism, for smoking, for inflammation, the idea that GLP-1s may be a longevity drug, especially in micro doses. We spoke in detail about dosing and how she titrates doses over time. In addition, we spoke about dietary changes that are necessary, physical exercise changes that are necessary to truly see the benefit of the GLP-1s. She spoke about going up too high on the dose can decrease satiety so much that people get worsening side effects. They get nausea, they get indigestion, they get constipation. But if you go up slowly, this often doesn't happen. And she has various supplements that she can use if it does. This was very interesting to me. We also spoke about weaning people off of GLP-1s. Is this possible? Or is it a drug they need to take for the rest of your life? And Bracha has different ideas of this depending on the situation, and how long somebody really needs to be on it depends on the situation before they even started. She talked about weaning the dose over, instead of every week, to every 6 weeks over time, and seeing success there, and using GLP-1s when needed, when things kind of go pear-shaped again for people. Discuss cycling GLPs, if this is a thing, side effects, mitigation of side effects, the optimal people to take it, and people that maybe shouldn't take it as well, potential ways to think about dietary changes and more of an ecosystem. And so what Bracha has developed is an ecosystem where her patients taking GLP-1s are required to have nutrition advice. They have group counseling. They have an emotional eating counselor as well, as this is such a big deal. So I really, really enjoyed this conversation with Bracha. We went over so many different aspects of GLP-1s, and I really felt that she knew the clinical side of this more than anybody that I'd spoken to before, because she's using it so much. Not only is she using it in herself to optimize her rewiring of her brain, as she called it, but also in her patients in an ecosystem. And I think that's key. We talked about the doc in the box that's giving GLP-1s to everybody. Should it be for people that are taking GLP-1s along with eating McDonald's every day? Let's talk about it, right? And we talked about some perspective that she has there. So I really hope you enjoy this podcast with Bracha Banayan. She was a fantastic amount of information, and it was so much fun to record with her. If you like this podcast, don't forget to like and subscribe below so you never miss an episode. On with the show. Welcome to the show, Bracha. It's good to have you.
Hi, good to be here.
So you and I met at A4M back in December 2024. You gave me the what is it called? Like the nth degree, like you fired questions at me for about 30 minutes straight. I'm like, wow, this lady really knows her shit and really cares about what she's doing in the world in New York and everything that you're doing with your companies. But so I want to talk about a lot of different things today with you. But the main one I wanted to focus on is something we haven't focused on at all in this podcast is GLP-1s. And so to start off, what's the story behind you getting involved and starting? I know you have the IV business, but when did you get involved in using GLP-1s in clinical practice and how did that come about?
Great question. First of all, me firing off questions sounds just like me, so it makes sense. I did that even though I don't remember. I think I almost got kicked out of school for asking too many questions. So my story in starting, I'll go back. I'll tell you my story in starting my company in general, IV Drips, where I am a family nurse practitioner. I worked in the emergency room. I saw how long people waited to get IV fluids. So people are waiting hours to get a bag of fluids that would have helped them feel better in 45 minutes. I said, this makes no sense. There has to be a better way to get this done. And so I created a company called IV Drips. This was before drips were a trendy, cool thing. Obviously, I got the domain name IV Drips. It's like getting Band-Aid.com. And so I created a company where I would send nurses to people's homes to give them IV fluids, comfort, frictionless, free, and one-on-one connection. And we've been doing that, throughout COVID. During COVID, it was a super busy time for us.
Sure.
Very grateful for that time to help many people. I gained about 15 pounds because I was working longer hours. I just started grabbing more carbs, and I just moved to the city. My lifestyle changed. I was going out with my friends more, drinking. Through that 2-year transition, I gained 15 pounds. I was thin my whole life. I never had something called the concept of food noise. I didn't really think about food. It wasn't a thing to me.
Right. Sure.
And so when I gained weight, I was this is I'm not accepting this. This is not being me. I'm not having to buy a new wardrobe. And I couldn't lose the weight. And it was so puzzling because usually when I put my mind to something, I could do it. And I just was but I'm hungry. It was very weird. And after about a year and a half of trying, I work out all the time. I eat healthy. In general, I'm very fit. I've always been going to the gym. It wasn't a new thing. I was this is not working. I need to figure out a better solution. A lot of my patients have been asking at that time for Ozempic. Because I didn't struggle with weight at that point in my life, I said, no, I'm not going to give you an injection to lose weight. That makes no sense. Just shut your mouth. Stop eating so much. I didn't really understand it. I'll be honest. I judged people. I was either you're being lazy or you eat too much. Why would you take an injection to lose weight? That makes no sense to me. And so I struggled with it and I couldn't lose it. And so I was I'm just going on Ozempic and I'm going to see how it works. I went on semaglutide. I lost 15 pounds in 3 months. I was this is crazy. Why do people struggle with weight? If there's something out there that can help them, it makes no sense. And from there, I started a weight loss program. After I went on it myself, it helped me. And then I also started learning other benefits about the drug that helped me. And I was this is a revolutionary drug. This is revolutionary. This is going to change our industry forever. And why does everyone not know about this medication? Everyone should be on it. Everyone should know about it. It's really cool. So I've been doing deep dives since then, putting patients on it for literally anything. I mean, we do it for binge eating, bulimia, anorexia, PCOS, smoking, drinking alcohol, and obviously weight loss, but just in general, inflammatory, IBS. I mean, we have been using it for so many things. Anyone who's in the GLP-1 world, we all know that it's a game changer in terms of medicine. If you're deep in it and you've been using it, you know how awesome this drug is. Most people just understand it as a weight loss drug, but it's a drug that will make people live longer. So.
Okay. Well, that's a great, I think, overview and first foray into the exciting world of what you've been doing. Because as you said, I think most people think of these drugs still as weight loss drugs specifically, but you just mentioned there, you're using it for anorexia and for IBS and for other sort of, gastrointestinal disorders and things. And I think that's it's very interesting. But before we get there, I think maybe just as an overview, what are these drugs actually doing as far as we understand, in the sense of what is a GLP-1? You can kind of go through some of the physiology, some of the medicine, just kind of give us so we're on the same page as we talk about how can this medicine that's working at, weight loss, but also have all these other potential benefits, kind of thing.
Yeah. So everyone looks at it as like a gut drug. Okay. It helps you lose weight, but it's actually a brain drug. Like I love it because it's a brain drug. So it's a gut and brain drug. And so
Okay.
how does it work in your gut? We know that it slows down your GI tract, which helps with many different things. One, you feel full for longer because you still have food there. But the other thing it does is that when it slows down your GI tract, the food is entering your intestines and your body at a slower rate, which means everything's getting absorbed into your bloodstream at a slower rate. So what's the difference of why do we care if things get like absorbed at a slower rate? Because then your blood sugar doesn't spike as high. So that's a really cool mechanism of what it's doing. So that's also how it works with diabetics. Like it's slowing down the GI tract. It also lowers your blood glucose level. But another way is that the way you eat now doesn't spike your sugar as much because of the slower process that's happening in your GI tract, which is really, really cool. You could do this naturally based on making orders of how you eat foods and just in general, like naturally you could have a lower glycemic diet. But even if you do that and you're on a GLP-1, like cool, that's like a game changer for never really having sugar spikes. Why do we care about sugar spikes? Because of inflammation. And we can get into that later. So and that's like directly correlated with helping people decrease their inflammatory response. Another thing it does is in our brain. So it affects our like hypothalamus. Believe it or not, we still actually don't fully understand how it works. And there's a lot of debates about what's actually happening in our brain. There's a few cool books about it already, but basically what it does is it's causing our dopamine like response to like usually you'll go the extra mile to eat that cookie, right?
Right. Reward signals, yeah.
The reward signals. And you're not going to do that when you're on a GLP-1. So you're not going to work really hard to get that dopamine hit. Now, how does the brain know, or how does like GLP-1 know for what should it do it for? Like
exactly, that's what I was thinking. Yeah.
People on it are not less motivated, right? Like I'm on a GLP-1 now. Like I still like I want to crush it in the world and do great things. It's not like lowering my desire to.
But you don't want the cookie.
Do things, but I don't want the cookie as much. So how does it know how to do that? And that's like kind of really cool.
Yeah.
And then it's like, but also it helps people like not drink or smoke. So how does it know to like almost all the bad things? How does it know to do that? We still kind of don't get it, but it's basically affecting a certain part of our brain that's causing us not to work as hard for like dopamine hits. They did studies with some mice, which obviously sometimes we like to look at the studies in mice and sometimes we don't. Sometimes it does correlate to humans and sometimes it doesn't. But let's say, for example, with the mice, they had like some alcohol in their water or just some sort of addictive type of solution.
Sure.
And when they were not on a GLP-1, the mice would like click the lever multiple times to get the fluids. But when they were on a GLP-1, they didn't hit the lever as many times. Like they didn't get it, they walked away. And so, I mean, they've done a lot of different studies with mice with GLP-1s and how much effort they'll take to get rewarding things. Even we saw that when the mice had a lot of processed foods, they would continue to eat even though it would hurt themselves, and they wouldn't stop. And we see that in humans as well. Like we continue to do things even though we know it's not good for us. So it's kind of like a weird thing. Like, why do we do that? Why do humans continue doing things that are bad for them? We do this in many ways, not just with food, but it's interesting. So what GLP-1s do, it's almost as like a pause factor. It like causes us like pause, like this delayed. I like to call it a delayed instant gratification. It's called the pause factor. And we teach patients like try to notice how this is happening in your brain, where you see something, you want something, and your old self would go for it and take it, but your new self on a GLP-1, you all of a sudden like, I'm going to pause. And it's not really like humans to pause. We like to react really quickly.
For sure.
So I kind of think if we continue like channeling these parts of the drugs, maybe even making it better, like if we were on these medications, would we all of a sudden become less reactive to multiple things in our life? And that's kind of cool. Like if we could all take a drug to be less reactive, less impulsive. I mean, I look at that as like a good thing. And then think a little bit more about the decisions that we're making. So that's like kind of what is happening in our brain. And because of that, you're making different decisions. So you're not going for the cookies or smoking or drinking, or because you're not getting that reward from it. And then you're feeling full for longer. So with those things, then you're starting to make different decisions. Then you're going to start losing weight. When you start losing weight, you're going to start having all the benefits of weight loss.
Right. Are you thinking that you can retrain the brain in certain ways with these kinds of, it sounds like you're educating people, right? And you're saying, look, watch for that pause factor, for example, but in the sense that this is a great drug for the drug companies, right? Because it is a drug that people, quote unquote, cannot get off of, right? Because you have these stimuli now that are changed. You have this ability to see this pause, but have you seen the capacity for people to come off these drugs if for various reasons? So say in the example, if you've lost your 15 or 20 pounds, right? You're feeling great. Now you're like, you know what? I don't want to be on an injection for the rest of my life. We don't know the long-term side effects of these medications at this point because they haven't been around long enough. We think that they're going to be fine so far overall. And we can talk about some of the side effects that you've seen and what's going on there, and maybe some of the misinformation as far as, things that you see out there and I see as well. But is your sense that people can come off these in various circumstances, especially, maybe related to some of these, things like alcoholism or smoking or even weight loss, right? What's your sense there? Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal troche. For this episode, check out our Tromune. Tromune is our high-strength cordyceps extract called cordycepin. This is an anti-inflammatory. It increases deep sleep. It's an antiviral. You take it at night and you feel better quickly. You can take it prophylactically if you feel like you're going to get sick. There's a lot of people sick around you. You can take it when you're starting to feel like you're getting something that's coming on. Take it immediately and you're going to feel better quickly. Check it out at transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show.
So, okay, first of all, people have been taking these meds for 12 years. Could there be side effects like what was the medication, fen? Like, could it be that like in 30 years from now, we're going to know something? Potentially, but it's in general like safe for diabetics and they have like all these issues. So, It could be that we'll see. There is an option that in 30 years from now, we're all of a sudden going to see. But at that point, I don't know if like people are going to be dying out of old ages. So like, I don't know.
No, I totally understand.
Be able to identify it. But I think it depends on the person and it depends on why you're going on it. So there's a couple different things. For me, for example, I went in it because my lifestyle changed and I started doing different things. And then I went in it and my brain changed. Like I changed my habits and I changed who I am. Like I don't drink alcohol anymore. Right. I'm not saying you'll never in my entire life see me drinking alcohol, but it'll happen like once or twice a year. It's just not who I am anymore. I just don't do it. I changed the way I think. I changed the way I act. The drug helped me realize that I'm not putting this in my body, not because I don't want to gain weight. It's because it's actually not healthy for my body. And it does something called real-time feedback, which I'll talk about as well, which helps you change your brain. But I do believe the drug actually rewires how people think if you're at the correct dose. The key to this drug and what everyone needs to know is the dose. That's really, it comes down to the dose. You have to know how to dose your patients on it, and patients have to know, like, if they're trying to guess what they're doing, they're making like a really scary decision because, like, you don't guess like your thyroid medication. Why are you guessing this? And so it all comes down to the dose. So I always look at it like this: like patients have an ability to make a decision, or people have an ability to make a decision about what they want to eat, right? And they like don't have a lot of self-control, let's say, or their food noise is really strong, and they suffer with that. And so let's say most people are like, who struggle with weight are like, here's like really, really hard, here, whatever. It's like hard for us. And we keep on making the wrong decisions because I don't know, mindless eating, impulsivity. Okay. You go on these medications and you have the ability to go like basically turn the volume to like 100 or whatever you want to call it, zero. Turn the volume to zero, meaning I'm never hungry. Like I'm dropping weight. I'm never hungry. Like I can go all day without eating. I can even go 2 days without eating. I'm just never hungry. It's amazing, right? The problem with this is that when you do that to a patient, or a patient does that to themselves, you put yourself at really great risk. You're always going to need that drug because you're not developing the muscles that you need to make different decisions. And so the second you go out so usually patients like lose a lot of weight, they're really sick, they're like, I'm nauseous all the time. And then they get to the point where like, this isn't worth it. People are so radical. It's like they go from like, I'm nervous, and then they go here, and then they're like, I'm going off of it. And then they gain all the way back, plus even more. And then also it's always harmful because one, you didn't eat. It is harmful. One, because you didn't eat correctly, but two, you now forgot what it feels like to be hungry. And you have this raging hunger, and like you're like not knowing how to eat, what to eat. And then suddenly your portions even become larger. And you're just like, I don't know, I used to eat till I'm full. And now I'm still eating till I'm full, but now it happens to be 3 portions. And so you're not developing the muscles to learn about how to listen to my body, how to eat correctly. And that's dangerous. So you need to always put a patient like over here, here, here. You have to like kind of like art and science together about how you're going to dose them so that one, they're like, I am hungry, but I actually went for the salmon instead of the cookie. And then I didn't need to eat the cookie because I felt fine. And then I had like a good dinner, and patients are starting to move away from processed food and more going to like whole foods. Those decisions that you hear people making when they're on the right dose are awesome. Those people may be able to go off of it.
I see.
It really just depends. Like menopausal females, I think they'll be able to go off it because their weight gain's more hormonal.
Sure.
And so they need like trizepatide to help move the hormone shift. People who suffer with obesity their entire life, you're talking about someone's brain that's really different. Going on this medication for a year and expecting them to keep the weight off will be really hard. They need to be on it more long term, but it really depends on habits and their environment, and if they make changes to their environment. Then you have like people who are like emotional eaters or binge eating. As long as they're in therapy, like you slowly can titrate them off of it. People who are on it for like inflammatory reasons like IBS, probably being on like a low dose will help them like for a while. It's not like it is lifestyle choices, but the medication itself is helping with the inflammatory pathway. So it's almost, they're using the drug a little bit differently than someone who's going on it for weight loss.
Right. That's beautifully said. And so maybe let's get into the dosing a little bit, because I think that's, you said, the art and the science here. So obviously it's going to depend on the person, and that's the art part of it. Maybe we can stick to the science part, like how you think about this on the science side. And then you were talking about how you try to navigate where you're not trying to give them like zero hunger signals at all, because then like that, the rebound of that is nasty. It sounds like.
Yeah. It's like people should not do that to their patients. It's really mean.
It sounds like you're saying like if you go all the way to zero and then you take them off the drug, it's like a crazy, horrible rebound kind of thing.
Yeah.
Yeah. So how do you think about dosing then? I know that there's different drugs, and you can, if you want to give an example of any of them, or you can definitely do that. But what's your sense? I mean, if somebody's coming on it for, let's say, I mean, there's different reasons, right? So if they're coming on from like an obesity or diabetic perspective versus if they're going on for smoking or alcohol cessation, where is the dosing in there? How do you start and how do you titrate typically?
Sure. Everyone's different. So one, I like semaglutide in general better. But trizepatide works better for people who have like really resistant to their body losing weight. Usually it's with people who suffer from obesity their whole life. They need like more receptors. They're a stronger drug.
Right. So maybe you could just tell the difference between the two, if you can just describe the difference between the two drugs.
One's a GLP-1 and one's a GIP. Okay, so backtrack. We have an active ingredient that we've been learning that helps with people. So that's called semaglutide. By the way, before these drugs, there was Byetta, Saxenda. These are medications that have been around for a long time that we've used for diabetes, right? But then your background is internal medicine.
Yep.
Yeah. So for all I know, you probably prescribe these drugs. So we've been using it for a while. And all of these help patients lose weight, but it's like we kept on advancing our game. And I think in a couple of years from now, I mean, Ozempic is going to be like, that's not as good as, the next one. But so semaglutide, then you have Novo Nordisk that patent Wegovy and Ozempic.
Right.
So it's an active ingredient. These companies patent it for certain indications. And then Eli Lilly went and they formed trizepatide and they patent it known as either Zepbound or Mounjaro. So they're the same thing. They're the same drugs, Zepbound and Mounjaro and Wegovy and Ozempic. Those are the same drugs with semaglutide. Just depends on the FDA's, depends on the indication. The more indications they get, then, the more people can get it covered by insurance. So that's really what's the indication game right now. And so with semaglutide, I in general like it better for impulses, meaning I think it helps with people's impulses much more. Trizepatide helps more with hormonal, or again, people who struggle with weight their whole life. I like the compounds better than prescribing Ozempic itself, because then I have to put the patient on 0.25. What happens if it's really high for someone? I have a patient who she was she was really struggling with her weight. She really wanted to go on it, but she's like, I am so scared to feel like I won't want food. And that scares me. Mm-hmm. And she's like, the first time I went on it, some doctor gave me the pen and I did 0.25. And she was like, I couldn't eat. I was crying for days. I felt horrible. Will it go away? I want my desire to eat. I don't want to shut that off. For her, it was too high. And so when you use compound formula, you could actually like play with the doses a little bit more. So like when we started her on it, we started her on like 0.05, like really, really low. And that was enough for just to introduce her body to the drug so it got over her fear of like the medication. And then she did really well with like 0.15. So she never even went up to 0.25. And then a lot of people like on 0.25, they feel nothing. I like to keep people as low as possible for as long as possible because you do feel tolerant to the drug, even though the drug companies like say no comment on that. But I see it, I see it with myself. I see it with my patients. Like eventually they need higher. So
people do need higher doses over time. Typically.
Oh, for sure. That's why if you go quickly, if you go up too quickly, or if you go to trizepatide as your first drug when you could do well on semaglutide, you're basically, if you run out, you're going to have to wait till the next drug comes out to help yourself if you're going up too high too quickly because you're not learning, right? It's all about learning. It's about the process. It's the emotional muscles that are built, right? Like even in business, we talk about like the process. The process is always key. It's like what you're learning as you're going to business, what you're learning as you're like doing things in life. It's never like the end result.
Of course.
The process gets you to the end result. It's like literally everything that GLP-1s teach us is literally like lessons that I learned that we learned this in life. It's not like the weight loss. It's the actions that you're doing that are going to cause your body to lose weight. That's going to help you have sustainable weight loss. It's not like you could use it as a cheat code, but it's never really going to get you anywhere long term.
Because you're always going to need more and more of the drug to get to where you are over time. And is what it
correct.
Right. Okay.
And, I don't know, maybe the medication isn't safe in high doses forever. Like we don't know what the next drug will be that maybe they'll always need to be on the highest dose ever. Like I think you should just be on a lower dose for as long as possible, getting the effects you need to get. Because if you're going to control your brain to a point that you're never hungry, that is like a really bad thing to do to your body. Like the drug was never meant to be used like that. This got way out of hand. The drug was meant to use with lifestyle modifications. That was what the drug was used for. And then people took advantage of the drug and just completely turned off their appetite, which was never meant to be. And the dosages that were studied for like diabetics or people with like severe obesity. No one needs to be doing 2.4 like 3 months in. It's just too high. So if you could stay at a lower dose for as long as possible until it doesn't work for you, then you go higher. But through that time, you should be making different decisions. Like you should be able to walk away from the cookie. And if you're not, then okay, let's talk about it. And if you're feeling nauseous and vomiting all the time because you keep on having the cookie, then you need to sit down with yourself and say, why do I keep doing things that are harmful for my body? And you need to be like with an emotional eating therapist and talk about it. You need to do multiple different things at the same time. You cannot expect the drug to just fix all your problems.
Yeah. What is your average dosing, would you say? I mean, maybe it runs the gamut as far as what you're using, but what's your average dosing for most people, when they're looking at it mostly from maybe from a weight loss perspective? Do you find that also would the average be different for somebody that's using it for smoking cessation or alcohol abuse, or is it all around the same overall?
Everyone's different. There are certain patients with like IBS for inflammatory. I usually end up tending to go lower. Like they'll do fine in like 0.5, 1. They don't go up to 2.4 because it's controlling their inflammation. We don't need to control their appetite so much. With smoking cessation, that's like a big, I see a big range. Like there are people that work really well with 0.25. Like they just don't have the urge to smoke or drink. 0.50.
So it could be super low sometimes.
It could be super low. Yeah. And they could just move up with time. But remember that they're not looking for that appetite suppressant thing.
Right.
So they're getting results from just the drug working.
Right. That's cool. And so that really kind of puts on the train for me is like, because I have a lot of people that are in like longevity communities now that are talking about using these drugs in sort of micro doses, if you want to call them that, right?
Yeah.
And I don't know what would be a micro dose versus what would be an actual dose. Maybe you can help me find that. But
I love that.
Yeah. But what's your sense from, I mean, that's where if you're talking about inflammatory downregulation in people with inflammatory disorders, but this is not for weight loss, this is for inflammation. Did you see this more in the train of and the ideas of how they could potentially be helpful in longevity as well. Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our metabolomics module. This is our foundational module at Home Hope. This is the module that's going to give you a foundation of how to understand vitamins, minerals, nutrients, cofactors. It's the real-time assessment of what's happening right now in your cells. How well you're making energy? How well you're detoxing? Do you have heavy metals on board? As a practitioner, this is a huge, huge upgrade to your practice. Check it out at homehope.org and use code podcast10 at checkout to save 10% on this module or any module of the Essential certification. Now back to the show.
Oh, I think they're the greatest drugs for longevity. This is a longevity drug, 100%. You take this drug, you'll live longer. I mean, okay, maybe I don't know everything, but I'm like pretty certain about that. Because
you think from like not only from like a longevity, but also from a health span perspective too. Like you're not just going to live longer with more chronic diseases. You're going to live longer. You think you have a healthier life using them.
Yeah, I think so. Because listen, I know like at the A4M, there are so many different supplements you could take to live longer.
Yeah.
And for me, I think that if you're able to lower your blood glucose levels, you will live longer. If you move a lot and you have low blood glucose levels, because the more sugar and insulin you have in your body, every single time you have something that spikes your sugar and insulin, you are causing an inflammatory response. If you have that time and time and time again over years, your body is going to react to that. And it comes into many different shapes and forms of chronic disease processes. So what if we can control that? And GLP-1s control it. They control it multiple ways. They control it by one, making you make different decisions. And two, they control it by decreasing those sugar spikes because your gut moves slower. And so
even at those microdoses too, like so even if like you're taking a microdose, you're still seeing better glucose control, even if it's not, in the sort of diabetic range or in like even the hyperglycemic range, right?
Correct. A lot of my patients, what I do, I tell them, like, especially people are not aware how much they eat. A lot of people are like, I don't eat that much. I don't get it.
Yeah.
It's quite interesting. I put them on a glucose monitor and their sugar spikes so high when they're like, I just never eat though. But then all of a sudden, I'm like, my phone's beeping. Like, what's happening at 11 o'clock at night? I thought you said you don't eat late. You're like, I forgot I had that cookie. I was with my friends. All of a sudden you become more aware. And that helps people. People who do the glucose monitor and do GLP-1s at the same time are like, they're going to have a really good journey. So we like tracking them with their sugar. So it's pretty cool. But it's great for longevity because you're having low sugar spikes, having low inflammation. Now, could you do this naturally? Sure. But how many people, yes, in the longevity world, more people are able to do it, but most of the population is not able to have a low glycemic diet and work out a few times a week and make sure they're getting like steps in, sleeping right. If that's like not how you grew up and if you're not having that mindset, then you should use a drug like a GLP-1 to help you get there. Microdosing is also really cool because you'll still get those effects, but you don't have the appetite suppressant as much, which is great. But eventually, once you start living this lifestyle, it's much easier to do. Like, the more processed food you have, the more you want it, the less your body has an ability to know it's not good for me. But if you never go near it and then you suddenly have it, you're like, that didn't make me feel good. So GLP-1s like just help people get there. And if you are on the right dose, you could slowly go off of it. And then I tell patients like either they go on our maintenance program. So we titrate, we never stop them automatically. We just titrate them down. And then sometimes I do it like every 7 days, every 10 days, every 12 days, every 14 days, every 3 weeks. And they touch base like, how are you feeling? I'm good. I didn't go back to my old habits or bounce back to my old habits, which is like, we didn't do a good job. You didn't do a good job. Like if I hear that after they're like slowly taking them off, then we know we got to go back up. It's like,
understood. Yeah.
I manage it like pain management. They say like when you're treating someone with pain management, you never allow them to feel the pain. You keep on like treating them until like you don't wait for them to like get to the pain. You treat them before. That's how I treat them while they're on the program. Like I don't want to have every month you mess up and have a cookie because you thought you could handle it. Like first develop the habits and then we can slowly titrate you off of it. Like you can't microdose or do it every once in a while when you start the program. You need to be committed. Okay. You need to do it correctly.
Yeah.
And then you develop new habits. Yeah.
Yeah. Is there a reason to ever cycle on and off in the sense that you cycle on for 6 months and cycle off for 6 months? Or I'm making up numbers here, but you're talking about weaning people down which I think is great. But is there any reason or indication to cycle, like that kind of thing?
Good question. So usually like either you're on the maintenance program, so you're taking it once a month, or you're taking it once every even 6 weeks.
Oh, wow. So you even extend people out that long.
You actually feel it that long suddenly because your body's like naturally starting to live that life. It's really cool. And then you eventually go off of it. If something happens, like for example, for me, I lost the weight for 2 years. Like I maintained my weight. I was off of it. I was on it for about 3.5 months. I was off of it. I traveled for 1 month. I was in Spain. I had tons of fun. I was eating. It's like, I got to try the food. I always have this thing. I have to try new things in life. I have to try everything in life.
Yeah.
So I just got off the bandwagon. I wasn't working out for a month. I had like a bunch of croissants, and I don't know if I gained that much weight, but I like changed my habits. And I got back to New York, and I was like eating the croissants in New York then. And I'm like, what's going on? So my habits changed. So I went back on it to like reshift myself. Not so much like because I need to lose weight, but I knew that if I didn't get something to help me change my habits, and I may gain weight. So I went back on it. And now I microdose on it. So I go on a low dose just because I like the inflammatory benefits. I just like what it does. It helps with like brain fog. And I see that more and more with menopausal women. So you take
Fog's a big problem.
GLP-1, you take methylene blue, you sleep a good amount of hours, you're like Superman.
Yeah. So that's why we're adding it to your regimens, right? with your GLP-1 patients.
Yeah.
So I really appreciate the perspective there, in the sense that you're trying to extend their doses, so that you're trying to wean them off, or just slowly increase the time between doses and see if their habits, stick. You mentioned a little bit earlier about emotional eating coaches and like that aspect of things. And that's such a huge piece for people that, most of us don't realize that we're addicted to food. You mentioned earlier, like people have no idea how much they're actually eating on a regular basis or when they're eating. How do you address that with people? I mean, it sounds like you have people in your network that you can refer people. How do you do that? Because it sounds like it's a really nice, like a holistic way of not just like injecting people and then saying, see you in a week, or like see you in a month for your next dose or whatever. Right.
So when they come to start the program, we make it very clear. One, it's not a quick fix. Like if you just want to sit on your couch and not do any work, then we're not going to give you the drug. They go somewhere else if you're just looking for a pharmacy. This is a program. You need to follow it. And they have to commit to doing either walking 7,000 steps a day, resistant training, at least 100 grams of protein, also weight dependent. So they have to commit to these things. And I like their patients like kick and scream, like, it's 2 weeks. I didn't lose any weight, blah, blah, blah. Put me up higher. I'm not putting you up higher. Like you have to follow the protocol. We also don't want to put people at a risk of like shocking their GI tract and putting it up too fast and getting them at risk for either pancreatitis or gastric paresis. And so they have to do lifestyle modifications to like agree to be on the program. And then the other thing that we added in, which is, I love this part of what we do, and I'm excited for the future of this part, is group support. So once a week we meet. Some people put their camera on. A lot of people keep their camera off because there's still a lot of shame about being on these medications. But group support's amazing. So like, it's either a nurse practitioner, me, or someone from our team. So once a week we meet and we talk about different topics, like how did it affect you and your brain? What are the habits that you notice that you continue to do, even though you're like, I don't need to do this anymore. And so people share it. It's so cool. Like one woman was saying that I always have a cookie with my tea in the morning. And now I like don't feel like I need to do that anymore, but I keep on taking it out because like that's always what I did my whole life. Like my mom always did it. She's like, I realize that's a habit that I can leave. Like I don't need to have a cookie every morning. Like I could eat something else, or I don't really need it. So that was like cool. People realizing like, I noticed that I just like after like dinner, I go home and I always like walk into my cabinet and I'm just, I just continue to do, I'm not eating anything anymore, but I'm like, why am I here? Those are habits. But then you hear other people talking about their habits. So we have like different things about like, and then people ask medical questions. And then we have a breathing coach who helps us with breath work, which is actually my brother. He's amazing at it.
I met your brother. Yeah, he's very. I didn't know you guys were brother and sister. Very different women from the outside. So very cool.
we are, and he's also like more calm, and I'm like, ooh. So, but we look alike. I think like our smile and stuff.
Yeah, you do. Yeah.
He does.
He comes in and does breath work. Yeah, okay.
He does breath work with them, and just like learning how to breathe, like breathing in through your nose and like your stomach and how you breathe in actually affects your nervous system. So like breathing is really, really cool. It's hard to do and it's like takes like a lot of dedication. And I'm like on this process of like I committed to myself like 10 minutes in the morning, 10 minutes at night. I've been doing it for 3 weeks already.
Congrats.
I'm so committed to it, but it's really cool. So that's like it's like a tool that you're building. The other thing we do is like we have a nutritionist that helps them like figure out foods, like good ideas. People talk about their like pain points and their struggles that week. That's kind of cool. Like when you're in a group support, then it really helps. And then we have an emotional eating coach who talks about like the things around it, like, shame. There are some people like there's like belief systems that people have internally, which is like interesting. A lot of people, let's say, who are like sexually abused, they feel like if they're thin, people will look at them more or they're not safe. And so they don't even realize, like, this is like a study that I read that they're just like, that if they're overweight, then they're not attractive to people and then they'll be more safe. And there's like huge studies around that. Or like there's certain belief systems that people have that they don't even know about. So when you go on a GLP-1, all of a sudden your brain isn't being filled with food noise. So you have time to think about, why do I go there? Like you can start thinking about other things with your coach because there are certain times it's not emotional eating, it's just habits or processed food and it's like American diet. And certain time it is an emotional component. It's not always emotional, like, so I think that if it is emotional, you need to deal with that. GLP-1s isn't going to deal with. Same thing with depression. Like you could take an antidepressant, doesn't mean it's going to solve everything for you. It's just going to help.
That's wonderfully said. I love that you have a whole framework there and you have a whole sort of ecosystem that you've developed to support people as they're going through. And I think one of the main things you just mentioned that I love to always emphasize is the parasympathetic activation aspect of things. So the breath work with your brother is great, that you're doing that twice a daily yourself, living in New York and the high charging. Like I think it's required because your nervous system in a place like New York City is already going to be more elevated. I was just talking to somebody that moved to Pennsylvania after living in New York for 5 years. And it's like every time you used to go to the grocery store, it's just a mission, right? Because you're in the grocery store with like 1,000 other people trying to go to the grocery store at the same time. So like I would imagine, especially in New York, that emphasis is going to go a long way to helping these people.
Yeah.
I love that. And so, one thing that I think we should, chat about a little bit here are potential side effects of GLP-1s, right? And we talked, this is obviously dose dependent, as you were alluding to, and I think that's important. And if you ramp up the dose too fast, you're going to have those more than you're going to have if you go slowly. But I think maybe talk about some of the major ones that you do see, how you address them, and maybe also, some of the aspects of, you talked about protein as well. And I think that's a big part of, when I initially heard about GLP-1s, it was like, you don't want to put people on these things. They're going to lose too much weight. They're going to lose most of their lean body mass and it's not worth it.
Yeah.
So maybe dispelling some of that. So starting off with maybe some potential side effects, dosing to prevention, and then we can talk about, how you eat on GLP-1s to maintain that kind of thing.
Yeah. So like, let's take an example of anyone who, let's say someone's overweight, they need to lose 100 pounds and they starve themselves. They're like, I'm just take Adderall. I don't know. They starve themselves. They're going to lose a lot of muscle as they have that journey. If they're not working out. If they are working out, they're not. But if they're not working out, then they're going to lose muscle. They're also going to have something, what we call Ozempic face and Ozempic butt. Even though they're not an Ozempic, it's just the fact that you didn't nourish your body. So
Ozempic face and Ozempic butt. Is that what you said?
Yeah. You never heard of that?
No, what are those? I don't know.
Oh God, that's so funny. Okay. So it's basically, people like say like, oh, look at that woman. She has Ozempic face or Ozempic
like
butt.
Really thin in the mouth.
Like really sagging. It's like patients go on at really high doses. They get really, really thin. They don't eat well. And so they suffer all those consequences. Like their hair thins, their face doesn't look as good, their butt sagging. So it's like a saying now. But anyone will get that if you're going to just lose a lot of weight really quickly. And so the key is, I love this drug. I really love this drug. I think it's great. But I think people have a very high expectation of it. It's gotten a little too far. And I think it's going to get worse because the next drugs are going to be even better. And so people are going on these medications and wanting to lose weight in 3 weeks. And they're like, but my friend dropped 8 pounds. And it's just this like obsession of how quickly I can lose weight and what everyone else is doing. And my friend's on it. And after 2 months, she was so thin. And people just realize like, it's just, they need to calm down. It's not about that. It's like, it's like comparing your friend who's just more successful in business than you. it's your journey. It's your process.
Totally.
Just like go through the process. And so like, I just see a lot of issues with that, like high expectation of the drug. It's like, even in relationships, like I really see Ozempic such a correlation with life, like in relationships, whether it's a romantic relationship or a business relationship, when you put all of your faith in that person, you're always doomed to be disappointed because it doesn't work like that. Like no one's going to fully make you happy and no one's going to fully do all the workload. It's a combination of multiple things together. Like anytime you put something on a pedestal, it's going to fall. And so you can't put Ozempic on the pedestal. You could take it together with lifestyle modifications and like get to where you want to get to in life, but don't expect it to do all the work for you. Don't. It's just not. And so I try to train patients about that sort of thing of like changing who you are. I always say you need to be a different, like if you're the same person when you went on and if you're the same person when you went on the drug as when you went off of it, then it didn't serve you right. You need to be a different person. It's supposed to evolve. You know, that muscle needs to be built while you're on it. So
yeah. I mean, I think talking about muscle, for example, right? You talked about how if you lose weight very, very quickly, you're going to lose a lot of lean body mass along with fat itself. And that's what you're talking about, the saggy face and the saggy skin on the butt and that kind of thing.
If you do it right, you won't lose the muscle. If you do it right,
so talk about that. So what do you typically recommend there as far as making sure that you don't lose your muscle and you maintain, and as you were, I think, just mentioning too, like the idea is not to lose weight over 2 weeks. This is a longer process, right? Yeah. Slowly do it overall. Yeah.
You don't want to lose weight too quickly because then also like you didn't change. All you did was take a drug to help you lose weight. You need to change. I would say, I don't think actually Ozempic, I haven't seen any studies that if you went on this drug and you lost 0 pounds, you lose muscle. I don't think the drug itself is causing muscle loss. Like I just haven't seen a study. It's always in correlation to the weight loss, which means it's the process. And so if you're working out, which I say do resistance training 2 to 3 times a week minimum, you have to work out. Like that's just like what's up. And it's not about weight loss anymore. It's literally being healthy, being in shape, especially for females. Like if you don't do resistance training, when you hit menopause and you're having low estrogen and progesterone, what are you doing for bone health? Like this isn't about being skinny anymore. You need to be strong. You need to be strong. Like everyone needs to shift from being skinny to strong. Like if you're physically strong, you feel physically stronger mentally. You know, you feel mentally stronger. So that is something that people just need to shift to working out, you know? When I was skiing,
go ahead.
When I was skiing, I was like grateful to like my body. I'm like, thank God I work out because like I was feeling a little sore, but I would feel like way more sore if I didn't work out and I wouldn't be able to do these certain movements. So like working out is important. And so I think our culture is moving towards that. You're seeing more runners clubs, Pilates, more boutique studios. People are moving towards like working out, and the world is in one way, I think we're moving towards like healthier trends, like with just, data, information, energy, how we're sleeping. We have all of this, like different supplements that are coming out. So many people, like just think about the longevity conference that we had, like how many with years it's growing, you know, methyl and blue. The world is moving towards health and wellness. We are moving towards. On the other aspect, you have, it's like almost like maybe even dividing. And the other, you're seeing people like that are having high processed foods, like not even educated about it. Obesity is at an all-time high. I think there's like this huge separation, which we're like going to divide in terms of like people who are knowledgeable about their health and people who are completely not. But but the muscle loss, I don't think is a thing. I think you just have to work out, and then it's instructions to take the drug. You need instructions, like eat with food, don't eat with food. You need to eat with you need to inject with exercise.
Inject with exercise. I like that. Yeah.
Yeah.
And I like the frame, and I do see this happening. I have young kids, and I do think that there's less, I think at least, emphasis on skinny and more emphasis on strong and having strong bodies and strong minds and things like that. In essence, that's a great shift. And that's one I think we all welcome for everybody. And I think it's an important one. When you're thinking about hydration status, when you're thinking about gastric motility, these are going to be important, right? And so I had somebody, for example, that was on a GLP-1 initially, and he wasn't having bowel movements. And he told me every 3 days or every 4 days he was having bowel movements. And so like, that's not obviously what we want to do, right? So just how do you approach that typically? And what kind of mitigation strategies do you use when people start having those kinds of side effects?
We have a couple of different supplements we recommend them taking, like magnesium. There's a few supplements that help with constipation. I would look at his dose and see if I can go a little lower. Also making sure you're hydrating. So it decreases your ability to know you're thirsty and hungry. So people don't hydrate enough.
So your thirst receptors do get mitigated on these drugs.
You need to make sure you're hydrating, like focus on hydration. I have them take certain supplements to help with the constipation. And then I also look at their dose and is it too high or something like that, and increase hydration. That's like something that I would do. I'm careful. We're very careful. We always tell patients, like, if you're starting to feel constipated, like, let's talk. And sometimes it's just a change of medication. Sometimes the dose is too high, but it's usually not a dosing issue. It's more of like, some people have those sort of side effects. Sometimes it happens for a little bit and then it goes away. But there's supplements that they could take for it.
So typically, are you kind of prophylactically putting people on supplementation when you're getting them started, like just so preventing constipation or like that kind of thing, or not typically?
No, because not everyone gets it.
Got it. Okay. It's not like, so would you say it's the minority of people that get the sort of the constipation, that aspect of things, or is it the majority?
No, small amount of patients. So it's like you have the constipation, you have some people have the nausea in the beginning. Usually it's affected to how you're eating, but sometimes there are a couple of people that just have the nausea. Not throughout the whole program, but just in the beginning. Another thing we see is like a lot of people, like 0.25 doesn't work for them. Sometimes it's like 0.50 until it starts working. Sometimes it's 1 milligram. So those are like the different complaints that we see. And then, upset stomach, like GI, like gas, bloatiness. Usually we look into their diet when that's happening, or their dose. Like when did you feel the gas? When did you feel the bloatedness? And so sometimes it's correlated with like a lot of fruits, fried foods, eating really late at night. Like if you're going to eat late at night,
just don't.
Yeah. Like what it does is it gives like real-time feedback. So like just pivoting the conversation for a second, we use something called the drop method at IVDrips, and it's dosing. So it's all about dosing. R is real-time feedback, which I'm going to talk about now. O is optimizing like your health and like listening to observing what your body wants. And P is the pause factor. I spoke about the pause factor and the dosing. R is real-time feedback. In general, how you eat, you're going to get feedback, but when you get the feedback. So most people get feedback like in their 50s. All of a sudden, they're, if a guy came to me and he's like, when I turned 50, all of a sudden I had diabetes, hypertension, this. The feedback is so lagging. Feedback is so long-term. So it's like, I don't know how all of those decisions that I made when in my 20s and 30s and 40s that affected me in my 50s, it's very hard to change. Very hard to change your behaviors when you get feedback 20 years later. Imagine like you ran a campaign, right, with your company, and like you only got feedback like 3 months later or 6 months later. It's like very hard to like navigate through that. But if you got like feedback right away, or someone on your team gave you feedback right away about like something how someone acted, or just how a phone call went, you're able to pivot much faster. So real-time feedback is really the easiest way and the fastest way to get humans to change their behavior. GLP-1s give you real-time feedback. So they're a coach. You inject this coach into your body. It lasts with you for 7 days. It's one-time fee for 7 days. Okay. It's so cool. And every time you do something wrong, it's going to tell you in the form of nausea, upset stomach, GI thing. You could either be upset at the coach and fire the coach, or you could start changing your behaviors. What do you want to do?
Yeah.
That's how I look at it.
Yeah.
So people who are like, Ozempic's so bad, it made me feel so nauseous. I'm like, and you just couldn't stop eating those fries. Like, going on a higher dose is not going to help you. You have to sit down with yourself and say, do I want to change? So
what's the O? You said that. What's
the O is like observing what your body wants. So like the working out, the eating, the protein, listening to your body. Like, your body's your temple. It's good to you. Be good to it. Like, I think we need to shift our focus on like hurting our body and just loving our body. Like, it's our temple. It's so good to you. It like lasts, like it's being good to you.
It's the only one we have so far. Right. Yeah. That's the only one. We don't have any other bodies to choose from at the moment. So
yeah, it's good to you. So it's like, I shouldn't eat this cookie because I'm going to get fat, or I shouldn't eat this cookie because my body actually doesn't really like, I'm like against processed foods. Like, I really try my best not to eat processed food, or I'm like alcohol. Like, I just don't believe it's good for us. So if you're just always saying, I'm restricting myself because I don't want to gain weight, or it's not I'm restricting myself. I'm making a decision not to do this. Like, I don't look at myself and say, I'm not taking any drugs. I'm restricting myself. No, I don't believe in it. I don't believe in, I'm talking about like, not like medical drugs. I'm talking about.
No, I understand what you mean. Yep. Yeah.
I don't do cocaine, you know, because it's not good for my body. I don't want it. I'm not restricting myself. I'm not, you know, and I think it's the same thing with other things. Like, we should come to a place where we look at alcohol and say, I don't know if an alcohol company would ever want to interview me.
That's okay. That's okay.
But we should look at it and say, it's not that I'm not having these things because they're not good for my body and my body doesn't process it well. Like, we should start doing things that are good for our body, that make our body happy, like long-term, not the dopamine hit, the long-term results, and make decisions based off of that. So that's the O part, like observing what your body wants, like respecting it. I think that when you shift focus, like you look at the culture in Japan and how they eat, like, I don't think they're looking at themselves as being restrictive.
No,
you know?
I agree. Yeah. Yeah. It's very difficult in our culture to have that delayed gratification, the delayed reward, as you mentioned, right? And that it plays into how Americans think about eating. You know, I'll sleep when I'm dead, you know, that kind of thing. Or that we had in medical school for me, it was, well, sleep is for quitters, right? That's what we thought of. And you know, that was the culture of American bigger is better. But speaking of American culture and American food industry, we've seen how a lot of these snack companies and their stock and their profits have gone down over the last several years. And now I don't know, I wanted to get your take on this, these GLP-1 snacks, like trying to basically find ways to get more calories into people that are taking GLP-1s. What's your take on this? And what do you think?
Yeah. So I think that, like, I think Coca-Cola is going to like pivot, you know, they're going to start coming out with, and all processed food companies, they're going to pivot. The smart ones are going to pivot. They're going to have foods that are higher protein and less sugar. If you want to stay in business, you need to do it. Now 1 in every 8 Americans on a GLP-1. Give it a couple of years, I think it's going to be 1 in every 4 Americans on a GLP-1. And so people are moving away from high processed food. They're moving, again, the world is divided, but I think
right, very divided. Yep.
As there's more indications, and insurance will cover these medications more and more, we're going to have more people on these drugs, which I believe, obviously my company is like cash paying, but what I want for the world is for it to be covered by insurance so that everyone can be on this drug, so that everyone could have accessible healthcare. Like, that is the ultimate goal. And I think that we're hopefully going to get there soon. And so the companies are going to have to shift. And so actually one of my friends is starting a company where it's like chips, like it's like raw vegan chips that are high in protein. Like,
okay,
Lay's potato chips has to become like Lay's with protein. Do you know that I just actually saw an ad with Cheerios and it said Cheerios protein? Like, because cereal is going to go out of business unless they add protein in their thing. Because if you have a food product that is going to spike someone's sugar, they're going to be on a GLP-1, and it doesn't matter what you have on your marketing. Your body doesn't lie to you. If your sugar spikes up, you're feeling nauseous. So people aren't going to take that product again. So they're going to have to put either high fiber or high protein in all of their things to decrease those sugar spikes. And so the food companies are going to pivot that way. We're going to see a lot more. People are going to become more obsessed with protein. Yeah.
So do you think they're going to go back to like smaller portions as well? I mean, in the sense of, you know, how portions are now compared to they were, you know, 70 or 80 years ago. If you went to McDonald's and got French fries, it was like this, you know, little thing of fries. And now you get a McDonald's and you go to a big fry thing, and it's like a gigantic thing of fries for the same size, right? So are we going to go back to portion control too? Or I'm impressed that you think that these companies are going to do that. My sense was they're going to find ways around it. Just like if you had a gastric bypass and you could eat through your gastric bypass, there's going to be ways that these companies are I'm going to try to develop foods so they can break through your GLP-1.
Could be, but I think people are becoming more educated. The CEO of Walmart, like last year, there was an article that the CEO of Walmart said, he's like, our food sales decreased. Like, people aren't buying as much in Walmart for food because it's like highly processed, high sugar. People aren't having it. Maybe the portion size will decrease. I think Uber Eats is going to see a decrease in sales because people aren't having those like late night snack cravings anymore. So I think that we're going to see it. In general, we eat like really large portions, I think.
Yes,
so,
we do.
like, I do these like street interviews, and like a lot of people sometimes I meet people from other countries, and they're like, yeah, the portion size here is like crazy, you know? So
Well, it's great. I'm happy you mentioned that. It was one of my last things to you, because I know you've been asking people about McDonald's and GLP-1s. And so I think I already know the answer to this, but I think it might be. So do you think that this is a drug that people should use if they refuse to change their habits, right? If they refuse to change, I'm not going to stop eating McDonald's. I'm not going to stop drinking alcohol. I don't care. I'm obese, but these are habits that I'm not willing to change, but I will take a drug to do it, to help me lose weight, because I know this is going to be helpful for other reasons. Do you think there's a role for it, or is it a way to get people in the door and then all of a sudden they don't want that stuff anymore, that kind of thing?
Obviously, I think that people should go on the medication when they're ready to change. Okay. Otherwise, they could go on it, but I don't think that they'll have long-term, sustainable results. They'll have to always be on it. I think overall they hurt the reputation of the drug. But if you ask me if I had a loved one who was at risk for a heart attack and stroke, and I knew that they would get a heart attack and stroke if they didn't take it, I think I would still make them take it because I'd want them to live. But I would hope that they change their habits. I think the way to use the drug is to change your habits. That's the way it was designed to be used. And it's a misuse of the drug to take it and not change your habit. It's a misuse of the drug. And that's what gives the drug a bad reputation. It's not the drug, it's the people that misuse it.
Well, and the providers too that are giving the drugs without the education, without the additional ecosystem that you've created at your company, and other companies are doing this as well. But we also know that there's somebody over there that's going to give it to you. You don't have to do anything, and just show up every month and take your drug and you'll be done with it, right? So it's an issue, I think, on both sides.
Yeah. I had one time a patient send me a text what they meant to send it to their friend, and they're sent my contact, and they're you could use her, but the weight loss will be very slow and you have to make changes. And this guy, and send a different number, but he'll let you lose weight really quickly.
Yeah. Yeah.
And I was we're up against. You should be happy that it's slow, my dear. She's oh, I didn't mean to send it to you.
Caught. But I mean, that's the world we live in, right? Because everybody wants this instant gratification. So I really do appreciate your perspective on this, Bracha. It's really been helpful for me to hear personally as I navigate this world from not prescribing these medications at this point yet, but only knowing people that are using them personally, or patients of mine that have been using them in various ways. So we're running up to the end of the podcast. I wanted to ask you one more question, and we asked this question to everybody at the end. The name of the podcast is called the Smarter, Not Harder podcast. And we ask all of our guests at the end 3 ways to live smarter, not harder. And these could be things that we've talked about with GLPs. It could be related to your IV drips company, your business acumen, which we didn't talk about, but you're just running a show over there in New York and been doing it for a while. And it's amazing. So anything, business, life, personal, 3 ways that anybody can live, smarter, not harder from your experience.
Great question. Okay. Let me have to think a minute. The first one that comes to mind is, working smarter, not harder is really finding the people that could support you to do the right things that they're good at. So for example, if you're running a business, I'm not great at running Google ads or finding the way to attribute which ad brought in what.
Sure.
But for me, working smarter would be finding the right person to run those ads.
Find the people. Makes sense. That they do stuff you can't do. Yeah.
Yeah. Build a good team. The other thing, working smarter, not harder, really just eating more protein and fiber and having a routine. So the walking and just sticking to a routine, regardless of how you feel, sticking to the protein. Weight loss is a hard journey, but it doesn't have to be that hard. If you just use the right tools, if you understand how to eat, meaning eat protein and fiber before you eat carbs. So that's working smarter, not harder, because if you eat your protein and your fiber first, you'll decrease your sugar spikes, and also you'll feel full for longer. And then another thing I would say, working smarter, not harder, really just, I think, going on a GLP-1 is working smarter, not harder. If you wanted to, I'll tell you why I'm saying that. Let's say you wanted to buy a building. If you borrowed money from the bank, put 20% of your own money down, then you could buy, let's say, a couple of buildings. But if you took all of your money and you put it all in one building, I think that's just working a lot harder, because now you're not going to have enough money to buy the second building. So it's you're leveraging the bank's money to do more stuff. So GLP-1s are just leveraging something that exists in the world to help you get to results faster. So whether you consider it cheating, I consider it just using leverage about what we have to help you get healthier faster. So yeah.
Well done. I like that analogy. That's perfect. Well, this has been great. I really do appreciate your time, Bracha. So if people want to hear more about you or learn more about what you're doing in the world, where can they best find you or what you're doing?
ivdrips.com, and our Instagram is ivdrips_.
I love it. So thanks so much for spending some time with me here after your beautiful trip to Switzerland. You know, it's good. You had to hang out in this podcast studio for a couple of minutes, but I appreciate your time. I appreciate what you're doing in this world, and hopefully we'll see each other in person again soon.
Yes, thank you. I appreciate you. Thank you.
Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. I had so much fun interviewing Bracha here for our podcast. Her company, the way she's creating an ecosystem for GLP-1s, seems like it's kind of like the gold standard of how to approach these things. And we learned so much in this podcast about how to dose them, indications, weaning, cycling, and so much more. I really hope you enjoyed it as much as I did. If you did, don't forget to like and subscribe below so you never miss an episode of the Smarter Not Harder podcast. We'll see you next time.